Okay.
Perfect.
Then I think we can start. It's 5 p.m. So welcome to the CMR Journal Club. It's great to have you all here and great to have two excellent speakers here with very interesting papers, I think. The common topic is aortic stenosis with a slightly different focus, but this will be very interesting, I think. So Sarah Nordmeyer is the first to begin, and she presents her JCMR paper, Circulatory Efficiency in Patients with Severe Aortic Valve Stenosis Before and After Aortic Valve Replacement. So the stage is yours.
Thank you very much. I'm just very, very short introduction. I'm from Berlin. I'm a physician, medical doctor in pediatric cardiology, actually. And in research, I'm affiliated to the Charité, so to the Institute of Computer-Assisted Modeling in cardiovascular medicine. And so in this work, we studied patients with aortic valve stenosis. And I think I'm going to start with the introduction, not with the abstract. So actually, we were interested in patients with aortic valve stenosis who are, like everybody knows here, suffering from chronic pressure overload. And this chronic pressure overload leads to different kinds of left ventricular remodeling, and mainly hypertrophy and fibrosis. The extent of hypertrophy and fibrosis finally increases morbidity and mortality. And the clinical solution in patients with aortic valve stenosis is the aortic valve replacement. However, there's always the question of when is the right time point to intervene so that left ventricular remodeling is not as far as the myocardium is already not able to regress anymore. The normal situation cannot be reached after aortic valve replacement. So we were looking at circulatory efficiency and to find a definition that reflects the ratio between the complete total left ventricular work the left ventricle has to perform in relation to the work which is actually only required for maintaining the cardiovascular circulation. So if we have, for example, a patient with increased left ventricular pressure and with increased myocardial hypertrophy, maintaining the cardiovascular circulation would need more work of the left ventricular, and thus the cardiac efficiency would be reduced. Other colleagues have studied cardiac efficiency or circulatory efficiency, however, then using positron emission tomography and CMR, so using a more invasive or radiation method, nucleic method, than only the non-invasive CMR method. So, and in a former publication, we already introduced this, we call it surrogate marker of circulatory efficiency, and showed differences in different stages of aortic stenosis. And in this paper, we looked at severe aortic stenosis pre and post AVR. So these 41 patients we studied were prospectively enrolled. We performed a visit 1 and visit 2, where we had CMR evaluations, echocardiography, clinical blood pressure measurements, and blood laboratory work done, and we had 10 age and sex match controls. I'm going once to table 1. This is a little jumping back and forth. So in table 1, you can see the cohort is in the mid-60s. We had equal amount of female and male patients. And in total, those were patients which are fairly healthy because coronary artery disease was an exclusion criteria. and almost 80% had a bicuspid aortic valve. This is a little bit special about this aortic valve stenosis cohort. Regarding the CMR protocol, we performed measurements to measure left ventricular mass, the end-systolic and anti-diastolic volumes, and used these parameters as well to calculate myocardial wall thickness and mean radius of the blood pool, which we need further on for calculation of the cardiac efficiency, circulatory efficiency. Flow measurements we performed in order to measure the contraction times, which is also part of the formula I'm going to present to you further on. We also performed global longitudinal strain measurements and feature tracking. And then coming to the circulatory power and efficiency, we used formulas for the left ventricular myocardial power, so for the total left ventricular work, using then parameters for myocardial wall volume, wall stress, and contraction time. And for the wall stress, again, we needed LV peak systolic pressure measurements and the radius of the blood pool and the myocardial wall thickness. And for calculating the circulatory efficiency, we not only need the left ventricular myocardial power, but also the circulatory power. So the power which is distally to the valve and describing the cardiovascular circulation. And for this, we use the formula using the mean arterial pressure and the effective cardiac output. And the circulatory efficiency, again, is the ratio between this cardiac output and the total left ventricular myocardial power. Additionally, we also measured diffuse myocardial fibrosis pre and post AVR and calculated also the fibrosis volume in these ventricles. So coming to the results, the clinical effect of AVR was as expected. Aortic pressure gradient decreased, NYHA classification improved, and we saw a reduction in myocardial mass and fibrosis volume and markers of heart failure. So here in table 2, you can see the pre-AVR values and the post-AVR values, and compared to the healthy controls. I just highlighted so the reduction of the myocardial mass, the decrease of the absolute amount of fibrosis, increase of global longitudinal strain, and reduction of NT-proBNP, and a reduction of NYHA 3 to 4, which was a reduction after AVR. But now coming to the circulatory efficiency. So we see in severe IS preoperatively the circulatory efficiency was lower than in controls. And we saw correlations between this efficiency, left ventricular mass, ejection fraction, fibrosis, NT-proBNP, and longitudinal strain. The left ventricular power was higher in aortic stenosis than in controls. The circulatory power, so the power after the cardiac output and the mean arterial pressure was not different at all. So everything was driven by the left ventricular myocardial power. And what did we see after aortic valve replacement? So after aortic valve replacement, we saw a significant increase in circulatory efficiency from 9 to 13. And this was not, the total cohort was not different to healthy controls anymore. So we would conclude in this part that circulatory efficiency normalized after aortic valve replacement. We saw correlations between circulatory efficiency post-operative as well with the mass and left ventricular ejection fraction. However, we did not find a significant correlation between the improvement in efficiency between pre and post and symptom improvement between pre and post. This can also be possible because actually we did not have patients who not really improved with their symptoms. So it could be that this cohort had just a too good outcome to find a correlation like this. We did also not find any correlation between improvement of the circulatory efficiency and prosthesis size. So this somehow did not matter. But what we found in the cohort of the 41 AS patients is that 10 patients did actually not normalize. Normalization is difficult because we don't have normalization, a lot of normalized data for this parameter. However, so in our control cohort, no patient had a circulatory efficiency lower than 10%. And so we actually just evaluated whether any patients did not show a circulatory efficiency after AVR of lower than 10%, higher than 10%. So we found these 10 patients, 24% with lower cardiac efficiency than 10%, and looked at preoperative findings. What we found that 70% of these patients were male, which did not was not significantly statistically significant. However, in tendency, the left ventricular ejection fraction was lower, and the diastolic blood pressure was higher in these 10 patients. However, there was no differences in a mean gradient across the valve, Nyha stadium, hypertrophy, fibrosis, and no parameter actually could identify a prediction why a patient or when a patient does not restore with the circulatory efficiency after AVR. The postoperative findings, we saw that only in the group with restored circulatory efficiency, we saw a significant reduction in fibrosis and improvement in Nyha. And again, what we saw in the group with circulatory efficiency not restored is that they had a higher gradient across the aortic valve, which seems clinically not really relevant, but was significant. And but again, they showed no differences in left ventricular pressure, antiprobetic cardiac function, and many other markers. I just want to show you the group. So the 10 non-restored and the 31 restored. The only difference, slight difference, was male, more male in the non-restored, but all others were not significant. And when we compared pre-AVR non-restored and post-AVR non-restored, compared to the 31 who were restored in pre-AVR parameters and post-AVR parameters. Well, the myocardial power and efficiency sure is different because this was how we decided to group the patients, but so efficiency postoperatively was 8.5, and in the restored group it was almost 15. Both groups, we saw a reduction in the fibrosis volume, but only significant in the restored group. And the left ventricular ejection fraction was significantly lower in the non-restored group. However, we saw only in 4 patients really reduced ejection fraction below 45, and the 6 others had ejection fraction of higher than 56. So it was not for every patient a reduced ejection fraction. And we saw the higher mean aortic pressure gradient. However, like I said, it's not even a moderate aortic valve stenosis. So we can't talk about patient prosthesis mismatch or something like this. The last result, I have to begin, is that we found a correlation between the preoperative circulatory efficiency to the postoperative absolute fibrosis volume. So suggesting perhaps that the lower the circulatory efficiency was pre-operatively, the higher is the fibrosis load after aortic valve replacement. Okay. Should I go on with the discussion, or do we discuss at the end?
Yeah, maybe we start a bit discussing with Q&A. So please put questions in the chat because we are quite advanced in time.
Yeah.
So maybe we can pick up a few points of your discussion as well here. So first of all, thank you very much. And sorry that I didn't mention your institution. I completely forgot it. Of course, this is important. Yeah, so maybe I start with the first question. There's nothing in the chat yet. I was quite surprised. So this is a very interesting concept, I think. And I was surprised that even after 4 months, was your follow-up interval?
Mm-hmm.
Did I get this correctly? So even after 4 months, you already see quite considerable changes. And I was wondering that it's a functional parameter, so this makes sense to some extent, but if a disease is like a chronic disease taking some time to develop and some time until valve replacement is performed, that the changes after surgical replacement are so fast. Is it what you expected, or would you expect to have longer follow-up intervals necessary to really see more improvement on that?
I mean, 4 months seems really quick, that's true, but the main change we see is the myocardial mass. And there is, we chose the 3 to 4 months, so it was in between 3 and 5 months or something like this. And we chose this according to pre-existing work as well, where they also described, they performed in the 80s, they performed histological studies, and they talked about you can have a normalization histologically after a year. And for fibrosis, it took up to 7 or 8, 9 years, I think. But they also talked about that the regression of the myocardial mass actually takes place quite quickly. And I think it depends also on this cohort, this special cohort, because we don't have a lot of we don't have coronary artery disease, and that's why we don't have a lot of LGE we don't have scars, and we don't have, well, I think in this cohort we rather have myocardial mass hypertrophy and actually not that much of real fibrosis. I mean, we have measurements of the ECV is 23. So it is somehow more myocardial mass than extracellular volume, like in other cohorts, I believe, because this cohort is really, it's a healthy cohort. It's somehow within the aortic stenosis, I think it's a special group.
Yeah, I agree. Yeah. Here's another question in the chat from Cristobal. You assume that the pressure is the same in both the circulatory part and the LV?
Wait. The circulatory part. I think I don't really understand what the question is. Wait, I have to look it up again. I can see.
Maybe I can just talk.
Yeah, please do so.
In the part where you define the formula for the powers, for the circulatory power and the left ventricular power.
Yeah.
Yeah, if you go back there, maybe.
I think you mean that well, we take, it's true, it's a very, very, very non-invasive method with limitations. So we take the systolic pressure, the right arm.
Yeah.
Yeah, the systolic pressure in the right arm and extrapolate this, that this would be the systolic pressure in the ascending aorta. And then we take the maximal pressure gradient across the aortic valve and we sum that up. And then we assume that this is the left ventricular pressure.
And how do you compute the pressure gradient? Using the peak velocity in the Bernoulli formula or something like that?
Yeah, well, the pressure gradient actually is echocardiography, the CV Doppler max.
Okay, it's 4 times the velocity squared.
Yeah.
Okay.
Okay, so because we're already advanced in time, I again thank you very much for your presentation, really interesting paper. And I think we move on to Alexander's presentation. Maybe you can unshare your screen and Alexander can share his screen. So we have another short article on the same topic, aortic stenosis, but this time diffusion tensor imaging is the focus of this recently published JACC cardiovascular imaging paper. And I'm happy to have Alexander here. He's a colleague of mine from Zurich. I was not involved in this study, so I'm really interested in what diffusion tensor imaging can provide us in aortic stenosis. Alexander.
Thank you very much, Bettina, for the introduction. Yeah, this work is a result of a cooperation between the ETH Zurich and the group of Sebastian Kozerke and Christian Stoeck, who is senior scientist there for cardiac DTI, and the group of Robbert Manka from the University Hospital Zurich. Yeah, we were very happy when we did this work on cardiac DTI in aortic stenosis, when we learned that it was accepted in JACC cardiovascular imaging. We were not so happy when we then learned that we had to shorten it to the length of correspondence, because this means that we have to scrap all the tables and most of the figures. So what we did is to upload the original version on medRxiv, so preprint server. And for the purpose of this presentation, I will switch between both of them so that I can show the tables and some more figures from the preprint server. But I will start with the motivation for this study. So even if aortic stenosis is the most common valvular heart disease, there are still many open questions, in particular regarding the optimal timing for valve replacement. And we know that CMR can contribute a lot to answer this question, particularly regarding the prognosis. We know that LGE in patients with aortic stenosis predicts the prognosis, and the same does extracellular volume. At the same time, there are drawbacks because LGE is not reversible after valve replacement, and ECV is also only partly reversible after valve replacement. The extracellular volume fraction even increases after valve replacements. And those patients who have an LGE or elevated ECV at the time of valve replacement, they still have an increased mortality even after timely valve replacement. So there's definitely a need for earlier markers of adverse myocardial remodeling due to pressure overload, and this is in particularly with regard to increasing evidence for early intervention in asymptomatic severe aortic stenosis that we've recently seen in the recovery trial. So our motivation was to see what cardiac diffusion tensor imaging can contribute and how it can characterize alterations of the myocardium due to aortic stenosis. So for the methods part, I will just switch to the preprint server. What we did is we recruited 21 patients, adult patients, who all had a severe aortic stenosis as determined by echocardiography. They all needed to have normal ejection fraction, so no low flow, low gradient aortic stenosis, and exclusion criteria were myocardial infarction or any coronary heart disease, any cardiomyopathy, and any other valve disease that was more than mild, except for aortic stenosis. We performed the CMR on a clinical 1.5 Tesla scanner, and we could recruit 11 of those patients who underwent aortic valve replacement for a second CMR 6 months after surgery. The DTI method that we used, the sequence is a diffusion weight and second order motion compensated spin echo sequence. For more details on this sequence, I recommend the work of Christian Stoeck in MRM. I will just name the most important features. So we triggered it to mid-systole. It was navigator based, and we had p-values of 450 in 9 encoding directions and 103 encoding directions. Additionally, we did a normal clinical protocol with balanced SSFP sequences in short and long axis orientation. We did LGE and T1 mapping pre and post contrast. For the post-processing regarding the DTI, the important parameters that we evaluated were the mean diffusivity and the fractional anisotropy as parameters for the diffusion inside the myocardium, and the helix angle, in particular the transverse gradient of the helix angle, what we call the helix angle slope, and the absolute E to A sheet angle. And I will give some more meaning to them, or some more interpretation to them later. We also evaluated native T1 and ECV. So the patient characteristics are shown here. We'll start with the patient in the control group and the baseline characteristics. The patients were slightly older. They were more bicuspid valves, however not significant, but as expected, the patient group had a higher cardiovascular risk profile, in particular hypertension, dyslipidemia, and obesity were more common in those groups. And as expected, the CMR baseline parameters of hypertrophy, meaning mass, and the septal thickness, but also the dimension of the left atrium were significantly higher in the patient group. When we compare the patients with aortic stenosis to controls, the first thing that we see is that there is an elevated MD, mean diffusivity, and a reduced fractional anisotropy. And we have a higher helix angle slope, which is highly significantly higher, and a higher absolute sheet angle. The images are shown here on the right side. So this is a representative image for the helix angle slope, and the slope is like the gradient from this negative angles on the epicardial side to the positive angles on the endocardial side. And this is a representation of the sheet angle, and you can see those dark red areas. Those are all areas with highly elevated sheet angles. When we then compared the patients before aortic valve replacement and after aortic valve replacement, we saw that all of the DTI parameters show a clear trend towards normalization. So MD and FA, both diffusion parameters, are significantly lower, or MD is lower, FA is higher after valve replacement. The helix angle slope reaches the level of normal controls just 6 months after valve replacement, and also the absolute E to A sheet angle is significantly lower, so more towards normal. Just for completeness, of course, also the myocardial mass and the septal thickness decreased after valve replacement. However, what we did not see is any significant change in native T1 and ECV, so they were not significantly different between controls, aortic stenosis patients, and patients after valve replacement. So for the interpretation of this data, I just switch back to this article, and I want to explain our findings on this figure here. So you see this tractograph showing the helix architecture of the myocardium, and if we cut out a segment, and we have here like one fiber for every depth of the myocardium, we can say that the angle of the innermost fiber to the angle of the outermost fiber is in healthy controls about 95 degrees. When aortic stenosis occurs, this angle gets steeper, so it's about 112 degrees. So the inner and the outer angles are steeper, and this is probably their hypothesis about what this could cause. They are actually more than 20 years old already, but that this orientation is probably can increase the twist that is seen in hearts with aortic stenosis and reduce the overall strain of the myocardial fibers. Now the sheet angle is shown here. So if we cut out a myocardial block and we look from the longitudinal radial surface on it, we see that those fibers are arranged in these sheetlets. And these sheetlets in aortic stenosis tend to fold inwards, so they are more horizontal. And this is something that is not fully reversible after valve replacement, in contrast to the orientation of the helix angle. This is the helix angle that we see 6 months after valve replacement is exactly the same that we see in healthy controls. Now, at the same time, compared to the normal values, we see increased MD and reduction of FA. So FA is a parameter of the directionality of the diffusion, while MA is a surrogate of the free path length of diffusion. So this means that there is increased diffusion. However, we don't see a change in extracellular volume. So our hypothesis is that the increase in diffusion occurs inside the cell due to cellular hypertrophy caused by aortic stenosis. Both gets more normal after valve replacement, however, not completely normal. And when we look at those figures and compare it to previous studies, we can say that the changes in MD and FA are very common in any sort of cardiomyopathy. So the changes that we see in aortic stenosis are like a sign of overall myocardial badness, the same as we see in HCM, in DCM, or in amyloidosis. It is different when we go to the orientational parameters. So the increase in absolute E to A sheet angle, that is something that is only seen in hypertrophied hearts. So the HCM and the amyloidosis shows the same behavior, however, DCM shows a different behavior. And for me, the most interesting parameter is the helix angle slope, because it seems to vary the most with different cardiomyopathies. So we see this steeper slope in patients with aortic stenosis. However, in amyloidosis, which is also very high, who also has very hypertrophied hearts, we see a much lower helix angle slope. So I think for phenotyping cardiomyopathies, the helix angle slope may be the most promising parameter. And with regard to aortic stenosis, when we compare it to the native T1 and ECB, we see that they have a much higher plasticity, so wider dynamic, and maybe more sensitive to early changes than those parameters are. Yeah, so in conclusion, I think we can say that this DTI provides a whole set of parameters that is good suited to phenotype myocardial changes in aortic stenosis, and may help us to understand the damage that occurs and the reversibility of this damage. But of course, this is a study with a low number of patients, and larger and prospective trials are needed to see if there's any predictive value in these parameters too. And yeah, that's what is from my part, and I'm looking forward to your questions.
Yeah, thank you very much, Alexander. Very interesting study, and you actually already answered all my questions I have written down. Sorry. So thank you for that. There is a question in the chat. Anna found it also super interesting, and she has a few questions. Is the diffusion sequence the same that is used in neurology? Maybe we start with that one, and then I'll read out the next one.
No, it is not the same. I mean, it's the same principle of encoding diffusion, but it's different because you have to adapt for the cardiac motion, of course. So you can't just use a neuro sequence and transfer it to the heart. You have to have a dedicated cardiac sequence that accounts for the cardiac motion.
Yeah, and then she wants to know how you make the reconstruction and if there is a particular software for that.
The reconstruction is done on a MATLAB software, which is custom built. So there is no commercially available software right now, but I think there is an Osirix plugin that can be distributed for DTI, but I'm not aware that there's any commercially available software.
Yeah, there is another question on the scanner which was used. You mentioned it, I think.
Yeah, I think it's a 1.5 Philips Archiva. Very so
standard scanner.
Yeah.
And a question from Sarah. How do you explain that there is no difference in ECV? It looks a little bit like some patients perhaps increase and some not. Did you look at the single patients?
Well, we had we didn't analyze ECV on a single patient basis. Actually, I think our study was underpowered to characterize the very subtle changes that you see in ECV. I think there are larger studies from Thomas Streibel, for example, from London, who showed that if you investigate a few hundred patients, then you see a difference there. And you usually see a slight increase in ECV in aortic stenosis patients, and then a higher increase in ECV after aortic valve replacement, which is due to the different timelines of the cellular remodeling and the extracellular remodeling. But we didn't investigate that in particular in this study.
Yeah, that's what we also saw in our studies. So there is a slight trend in your study too towards higher ECV
Yes.
post AVR. So maybe if you have more patients, this will become significant actually. Yeah, okay. So we are already 10 minutes over. So thank you again. It was a very interesting session today. And I'd like to hand over to Matthias. Maybe you can unshare your screen, Alexander, that he can present what the next journal club will be about.
Thank you very much, Bettina. So next time, that will be June 2nd, we'll go to something very interesting, which is new stress protocols for CMR, not using needles. And there will be two papers presented. One is on CMR strain imaging in patients with acute chest pain. And that's work from Heidelberg. Actually, it's both work from Heidelberg. And I have to disclose that I was involved in both, but nevertheless, I found them interesting. And the other one is also using strain imaging, but then combined with a breath hold maneuver. And the papers were published in PLOS ONE and JACC Imaging. I'm really looking forward to that and hope that all of you can attend. It will be a very interesting discussion and possibly a new avenue for CMR in the future. Thank you. Back to you, Bettina.
Yeah, I'm looking forward to it. I like the idea of getting rid of the needle.